And we have the last case. I think it is a very short case. Dr. Ahmed Nassar, the only pediatric neurologist with us today.
And not MS.
And not MS.
You never know.
Yes, I would like to thank Dr. Nermi for allowing this chance to present this case.
Little one.
So our case is 7.5 years old male with no family history, consanguineous parents or marriage, no family history of epilepsy or abnormal movements, developmental history, global developmental delay, stationary, and the acquired skills, but he is still delayed. IQ 89. Seizure history, onset at 2 years. Type of seizures, abnormal events looks like left focal aware seizures with abdominal aura and calling parents, plus or minus bilateral tonic-clonic, but very rare to evolve to bilateral tonic-clonic. Body weight 22 kilogram, and by examination there is no weakness. EEG, interictal EEG, as Dr. هشام will show. هقول الانتريكتال بقى وانت قول. هنشوف الفيديوز ويعني.
Well, I have the source images, but mainly this patient did long-term EEG twice, and both of the drawings showed no interictal activity. So the background is basically normal. The first drawing had just one event, and the other one 6 events. So I have the source file for the one with the 6 events. So please proceed.
There is no interictal discharge. Ictal EEG.
I have the source image, but you can please show these.
Oh, okay, I will show semiology.
So you know, Dr. Gerald, when
the semiology is abnormal choreo-aesthetic movement to the sonic movement in left hand and left face, lasted for 50 to 60 seconds.
the thing is, when they send the patient with a semiology chorioathetosis left, I was like, this is a movement patient, so probably I would normalize this EEG. And with the first drawing, there was no EEG correlate to this event. So I was like, okay, this is a piece of cake. Let's just normalize. And then I said, why not go for another drawing? And surprisingly, seizure 1, no EEG correlate. 2, no EEG correlate. Seizure 3, there is an EEG correlate that is very convincing. So may I please show you this EEG from the source file?
You went back to look at did you use that to go back to look at the other EEGs and see anything?
I did go back once and twice, but I couldn't see anything there. I could show you all 6 seizures, but
that's okay.
This is basically the...
So movement disorders are epilepsy of the basal ganglia, and epilepsy is a movement disorder of the cortex.
Okay, could you please just follow through whenever you want me to freeze? Okay. I don't know if you could appreciate that there is rhythmic spiking in F4, C4. Yes. And then you're starting to see it, there was some spatial evolution into the P4. Could you appreciate that? So we're on the same page, and you could actually look at the semiology and watch this exact same event that it's basically side-to-side head movement with some choreoastotic movement of the hand.
I think there also relative immobility in the right side.
Yes, and you know what was more confusing? Our technologists are usually trained to do some testing for psychogenic or non-epileptic events. So I basically asked them if it's a movement disorder, maybe suggestibility wouldn't cause a factor. but that the parent provoked one of those seizures by suggestion. So that's weird. And on another event, I would show you this, the other event where I told the technician actually decided to, let me show you this. He asked the patient to suppress the event.
And he respond.
And he responded. I don't know if this is the one. No, this is not the one. Let me show you another. No, not this one. Sorry. Yeah, probably this one. No, not this one. حاضر ثانية واحدة. I think seizure 4. No, 2, 5, 6. I was pretty sure it was 6. Anyways. You want to see the patient's face? Yes, no problems. 1 second. Sorry.
الكاميرا الثانية.
Full screen. I think the face is more apparent here. Just give me a second to start from the beginning of a seizure. Okay. Not this one. Yeah, no, this is nothing. Yes, continue.
So we recorded multiple events. One of them was right. I think his face is seen his home videos. Yes. It lasts for 56 seconds in attacks. In the first 2 years ago, there were 2 to 5 attacks per day. Now 15 to 20 events per day. In between, normal. There is no weakness. Baseline return to البيزلاين between the attacks. So we do MRI 1.5 1.5 Tesla protocol. There is right central abnormal gyrification. دكتور مايكل ممكن يشو MRI. Normal gyrification, right pericentral. ونشوف الام ار اي والبيت
Okay, this is the only abnormality you could detect. I don't know if it's not abnormal. If we can say it's a dysplasia or not. It's not. So here is a central sulcus. And up here, it gets messy. It's not a clear, thick, thin relationship.
What about the gyrus anterior to that?
Yes,
That one.
I was going to take about that. A little bit thickened here. Here. So we talked about the berry area here, but I'll show you in the flare. Here. So at the bottom of, I think, 2 or 3 slices, but in the coronal, if I just move here.
For the audience, 2 important features are you see this on 2 different sequences, and
Yeah.
you see it in 2 separate planes.
Mm-hmm. Just one moment.
So what are you going to do?
Because it's very uncentralized. Here it's centralized. So we can check. So do you think?
It's not normal.
Yes, yeah. Yes, okay. So now you can check it again.
So yeah, I mean, I think there's a dysplasia. The issue is how extensive is it? And you had a PET scan,
Yes, we have it.
and how was it interpreted?
I have it here. Here is a cortex of question. So what do you think?
I
Here.
think the child's got a malformation of cortical development that explains that's compatible with his EEG and compatible with his event.
Is it early enough for him to remodel if you remove it? He can substitute functionally.
In terms of
his arm.
Well, if it's anterior to his motor cortex, he'll be fine. If it's in his motor cortex, then no. I think that's hard to know. I really would appreciate someone who's a movement disorder person talking about this, but the home video to me was pretty convincing. I also don't know whether he's got both. I mean, he might get, is his awareness impaired when he has his events? Is his awareness impaired?
No. He's fully aware.
Focal aware.
Focal aware? Yeah, so he has epilepsy. So, and it's, now does he have, now whether or not he has learned to have other events on top of that is a separate issue.
I just wanted to show you if suppressibility counts in this when the technician joins the room. So he starts these abnormal left-sided movements, and there is no EEG correlate. And then
but
the technician joins, and he holds his hand and he asks him, "Can you suppress these movements?"
And not really.
I don't know if this is called suppressible or not.
So I mean, it's very peculiar, but if consciousness is not impaired, then the surface EEG will not show anything half the time. And you have a seizure with C4 spikes that goes along with the dysplasia, that goes along with the movement disorder. So I mean, he clearly has epilepsy. The issue is everything epilepsy? And that I don't know. I also don't know, because this is peculiar, I mean, an epilepsy should not be suppressible. I mean, that's one of the cardinal rules. On the other hand, if awareness is not impaired, and you could imagine a situation where you may be able to modulate that expression to a certain degree. So whether or not this is, if he stops for 5 minutes and goes on having a seizure, then I would be concerned that some of these are not seizures, but some of them clearly are. Yeah.
ما هو بيevolve
I think it's really hard to say definitively there's no correlate in this kind of case. Yes, sometimes it shows up better than others, but it would be much easier if you had intracranial monitoring to be more sure. Because when they used to look at those overlapping cases of maybe a movement disorder versus epilepsy in sort of dystonic patients, they discovered when they actually put intracranial monitoring that in fact some of those movement disorders were epilepsy.
Yes.
And that's why sometimes the movement disorders also, you could argue, is why they respond to carbamazepine. Or,
Yes.
you know, there's definitely an overlap. This is a great case of a child who probably has an overlap syndrome that is likely focal epilepsy, and it behaves occasionally like a movement disorder. So yeah.
He's drug resistant currently. We tried sodium channel blockers. Initially, he responded well, and then the episodes became more and more frequent. They currently occur on a daily basis. So he's a drug resistant epilepsy patient, and the lesion is in the vicinity of the motor cortex. So if we are considering him for further surgical management, could we go safely for surgery in this particular area, or do you think that the motor strip might have been migrated away and he might need fMRI for motor functions? Maybe the motor strip has migrated because this is a congenital lesion or something that is developmental.
Yeah, I mean, I would do a functional MRI to identify his motor cortex. I kind of think motor cortex might be just posterior to this.
Yes.
And you might be able, the other thing is because if it were motor seizure, he should be jerking and twitching. He shouldn't have
this choreography.
He should have so I think he's probably okay from that point of view. But you got to find out.
Okay. Thank you.
The thing is that it only occurred during wakefulness, not sleep. Does that change anything about it?
No.
Seizures can occur. Yes.
And out of curiosity, has the previous case or this case had genes sent, given the history of consanguinity, and especially the last case where the MRI is not?
You want to do whole exome for him?
So the case, the immediately preceding case,
the one with Ala?
Because there was some consanguinity and the MRI is a little bit unclear. I would genes, and also when
in this patient, no, family history is irrelevant. But for Ala,
yeah.
Yes, there is both a family history. ولاد خالة يعني في both consanguinity and في family history maternal cousin diagnosed with MS at the age of 22. Yes. No.
Sorry, last question about this
So
case.
we,
Do you think at this point of investigations, even after we do the function MRI and all these issues, do you think this is enough to go for surgery, or intracranial monitoring is required first?
Well, I think if you have a clear lesion, you take it out. The issue to me is whether it's one gyrus or two gyrus which are affected. I think it's two, which makes it a wider resection, which makes it more challenging for you. My surgical colleague increasingly wants to stick pins in everybody before we resect. so, and if you were French or Italian, you would stick pins in this person. So, I think there's a long argument for whether you just take out the lesion, or if there's something sufficiently odd about it that you want to make sure how extensive your resection is, then you would put in stereo EEG. The caveat to that is, with bottom of the sulcus dysplasia, you can be off by 4 millimeters and miss the focus. I mean, so it doesn't take, it can be very, very specific. So that's just kind of the only caveat. And the other issue is whether you need to do any motor or language mapping. So the child is right-handed. The child is right-handed. Is the child right-handed?
right, yes, yeah.
Right. So you would also, but 5% of people who are right-handed have left hemisphere, have right hemisphere language. So you would want to do motor mapping plus some language mapping in this child.
Yeah. Okay.
And then it's
Because
easy for you to take out.
It's very, very uncommon. We did such cases, some of such cases which are dysplasia and bottom sulcus in the motor cortex, but the semiology is very, very relevant and uncommon. That's why I'm asking for, just to make sure by intracranial monitoring first, just to make sure that it's not at the end, it's not epileptic.
Yeah, well, but I think, as Dr. Ting says, he's got stereotyped events. He's got an EEG, at least one of which goes along with the event, and he has imaging that goes along with the event. So he's got a duck, and a duck. So he probably is a duck. But not a quack. We're the quacks.
Okay, thank you.
I would just like to thank the presenters for their excellent cases and for being patient with us. I'm sure these are the simple, straightforward cases that you meet with every day. But we very much appreciate the challenge that you have presented with us today, and I hope the audience has enjoyed that as well.
Thank you.